Great, thank you very much. Let me just share the screen real quick. Can everyone see my slides? Okay, great.
Yes, we could.
Great, everyone can hear me, right? Okay. So my name's David. I'm one of the emergency ultrasound fellows at Harvard, Massachusetts General and Brigham and Women's Hospital. I'm actually just about to finish my fellowship year at the end of this week. And I'm honored to be invited to speak at this conference. And just going to talk to you guys today about appendicitis. And I also decided to add SBO to the discussion, small bowel obstruction, just because they're kind of related. And the discussion on appendicitis, there's enough time to fit both appendicitis and SBO into this discussion. And this will be a very practical discussion, basically mostly of how to do the exam and how to troubleshoot, like when you run into issues of finding the appendix, for example, and also just what the pathology looks like. What are the signs that we look for on ultrasound and some of the specific measurements that we take. So let's go ahead and get started. This will be our overview today. We're going to start off by talking about appendicitis. We're going to go over a little bit about anatomy, and then we'll be focusing most of the talk on the actual ultrasound technique and ultrasound findings. And we're going to do the same thing with small bowel obstruction. And this will be a very casual discussion. So please, if anyone has any questions, just go ahead and unmute yourself and speak up. I don't have easy access to the chat box. It would be better if you just speak up. We'll also have time at the very end for a Q&A session. All right, we'll get started with appendicitis. Just some quick anatomy. So the appendix is this vestigial organ just off the end of the cecum, and then just before the beginning of the small intestine. So it's at the corner of the cecum and the ileum. And when we try to look for an appendix on ultrasound and we give you the landmarks to try to look for it, those landmarks are really only useful for looking for an appendix, which is more anterior. But as we know, an appendix can be in a variety of positions. And specifically, I want you guys to pay attention to the percentages here. And these are the rough estimates of the percentage of time that an appendix appears in each of these anatomic positions here. Specifically focus on this one, retrocecal appendix. This is when the appendix actually curves behind the cecum, posterior to it. That actually occurs a lot more often than we think. Actually, the majority of the time, roughly 25% of the time, the appendix will be retrocecal, which makes it pretty much impossible to see on ultrasound through the traditional landmarks. We'll go through the traditional landmarks, and then we'll talk about a few tips for how to find an appendix when we think it could be retrocecal. And here's just another zoomed in image of what a retrocecal appendix, like where it lies anatomically. It's this dotted portion right here, right behind the cecum here. And the other literature shows it could be even up to 43% of the time, the appendix is in a retrocecal position. Pretty high percentage of the time. All right, so for the actual ultrasound technique, we'll be using either a linear probe or a curvilinear probe as demonstrated up here. Ideally, we would use a linear probe because it has the best resolution, especially for superficial structures. If a patient is larger, obese, there's some fat overlying that appendix, then we would go with the curvilinear probe to get deeper penetration. But if you want the highest quality, highest resolution images, linear would be the way to go. And the number one tip for finding the appendix is just ask the patient where it hurts the most, ask them to hold up one finger and point to exactly where it hurts the most. And that's where you start. Traditionally, it's at McBurney's point right here, which is 1/3 of the distance between the umbilicus and the anterior superior iliac spine. But really, it could be anywhere in this right lower quadrant area. So you just go where it hurts the most, and most of the time you'll find the appendix most easily that way. The second most important portion of the exam is to use graded compression. And what do we mean by graded compression? Well, basically it means you just slowly press down and apply gentle pressure, gentle but firm pressure. And you slowly let go, move a little bit, and do the same thing. Apply gentle, firm pressure. And the reason for that is there's bowel gas anterior, gas floats up. So it's anterior, gets between the probe and the appendix or any organ you're trying to look at. The gentle pressure pushes the air away. And you have to do that because ultrasound beams do not transmit well through air. So the graded compression helps move some of that bowel gas out of the way so you can actually see the organs. You could sometimes ask the patient to cross their right leg over their left, and occasionally that could bring the appendix more anterior. And these are the traditional landmarks that we'll be looking for. And we'll go through it in more detail later, but basically for most lateral, you will see the iliac crest, and then you will see psoas muscle as you go more medial. And the most medial structures are the external iliac artery and vein. And we should expect to see the appendix, if it's an anterior lying appendix, just sitting anterior to the artery and the vein. And you can also, if these techniques fail, you could try lawnmowering the probe in the right lower quadrant, meaning you just systematically go superior and inferior as you go laterally and make sure you cover the entire right lower quadrant. And finally, we'll talk about a left posterior oblique position, which can be used in some cases to look for a retrocecal appendix if it's behind the cecum. Now, these are the traditional anatomic landmarks we look for on ultrasound, starting with the iliac crest, which is the most lateral. In this video clip, it's going to be the green highlighted structure right here. I'll just pause it right there. So this is where we're starting. We got either the curvilinear probe or the linear probe in the right lower quadrant. We ask the patient to go where it hurts the most. We go there, we use graded compression, and we just don't see the appendix. That's okay. Now we go a little more lateral. So move the probe a little more lateral along the body near the hip bone. And this hip bone is the iliac crest. And you know it's bone because it's hyperechoic or bright right here with posterior shadowing. Keep moving lateral on the human body until you see this bone. And then you're going to move medial. Now, I slowly move the probe medial. Keep going, keep going. And now right here, you see this muscle come up. This first muscle that you see, this first prominent large muscle as you go medial is the psoas muscle. And it's going to be kind of posterior, most posterior structure. And as you go even more medial, you start to see these vessels come up. Right here is the iliac artery in red coming up right there. So if we rewind, let's rewind the clip. We start lateral again. You'll see the iliac crest in green. Keep moving medial now, medial, boom. Now you see the psoas muscle popping up, and then you see the iliac artery. And ideally, you would see an anterior lying appendix about right here in this general area, usually sitting on top of the vessels. And that's like the traditional area you'll be looking for the appendix. I'll be honest with you, most of the time, I do not see the appendix in that traditional position. Because as we saw earlier in the previous diagram, the retrocecal position is actually the most common one. And there's a variety of other positions that the appendix could be in. Here are a few other traditional images. You have the psoas muscle labeled with a P. And you have the iliac vessels right here, iliac artery in red, iliac vein in blue. And right on top, this is where you would expect to see the appendix. And this is where you see it here in this image. And this is just a schematic of where that appendix would be if it's in this traditional position, just coming off the cecum, overlying the iliac artery and iliac vein. All right, so right here we have, so if using those landmarks, you still don't see the appendix, the next thing you could do is you could look for the cecum, and then you could look for the ilium. And the ilium is the end of the small bowel. The cecum is the beginning of the large bowel. And we know the appendix should be coming off the cecum, and it should be somewhere in between cecum and ilium. In this image on the left, we see cecum right here. So it's going to be, so that we see the psoas muscle from the previous video clip. And as you go lateral again, here's cecum. And you know it's cecum because it's filled with air. And we know this is air because there's this hyperechoic line, and then everything below it is just shadowing. And this is called dirty bowel shadowing. And it kind of looks like lung, and that makes sense because both lung and bowel are filled with air. So they would look similar on ultrasound. So basically, right here, this is all cecum right there. You see these bright little hyperechoic structures right here. And then you see shadowing, dirty shadowing behind it. That's what bowel looks like, or air in the bowel. And it's just lateral to the psoas muscle. Ileum is also going to be filled with air, so it's going to look quite similar. It's just going to be medial to the psoas muscle. So you go from that same area and they move medially. Here you see the external iliac artery. Medial to that, you'll see ileum right here, this peristalsing structure right there, also filled with air. These bright hyperechoic findings on ultrasound indicates air. And now that you know where cecum is, and you know where ileum is, you know appendix needs to be somewhere in the middle. So you would just be keeping your eye somewhere in the middle. And that's usually like where the psoas muscle and the external iliac artery is as well. All right, so let's say you went through all that and you still don't see the appendix. Well, we could try this position called the left posterior oblique position to look for a retrocecal appendix. This was described in a couple papers, and basically the position looks like this. You have the patient lie on their left side. It's almost like a left lateral decubitus, except you're having them even more like completely on the left side. And then you take your ultrasound probe, and you're going with the probe marker pointing up towards the patient's head, you're going to place it right there on the patient's lateral flank. And the idea behind this is that the cecum is going to be in this right lower quadrant, and that appendix is supposed to curve behind the cecum. If it's behind the cecum, the air in the cecum will be blocking your ultrasound beams from penetrating it if you're looking anteriorly, like from this traditional position. But if you put your probe behind the cecum, you should be able to bypass that the dirty shadowing from the air within the bowel in order to see the retrocecal appendix. And this image on the left here is if you have the patient just lying flat on their back as usual, and you're trying to scan anteriorly to look for the retrocecal appendix. You see here is the cecum with the bright, dirty bowel shadowing inside, and the appendix is somewhere down here, but it's obscured by this, the bowel shadowing. However, if you have a patient lie on their left posterior oblique position, which is what this image shows, then you have this dilated appendix popping into view right there. And you have the psoas muscle right there as well. Here's another example where you have psoas muscle. You have the iliac vessels right there. You have small bowel right here, which is the ileum. And we just don't see the appendix in this view, but once you have them lie on their left side, this is where you see appendix, this tubular structure right there. It's just anterior to the psoas. And it's occasionally this left posterior oblique position could work. So it's worth a try if you're trying to look for a retrocecal appendix. Let's say you have either a pediatric patient or a very skinny patient. There are a couple papers that demonstrated some case series that showed appendix being found in the right upper quadrant, actually. And so this paper shows 5 cases of a retrocecal appendicitis found on bedside ultrasound by a pediatric EM physician. And right here, you see your traditional right upper quadrant view with the liver here. See, you have the gallbladder right there. And right here, you have this tubular structure, which is a retrocecal appendix. Same image, different patient, same position here, liver, and this is just like some subcutaneous tissue and fat. And then you see the appendix popping into view right there in the right upper quadrant. So basically, it just goes to show it doesn't hurt to try the right upper quadrant, especially if you have a particularly small or skinny patient, and especially in pediatric patients. So just in summary so far, we basically take the probe and you go where it hurts the most. If that doesn't work, you're going to start lateral and look for the iliac crest, and then you're going to start moving medial. You're going to see the psoas, and you can see the iliac vessels, and just anterior to the iliac vessels is where you should see an appendix if it's in that anterior position. You can also have the patient cross their right leg over their left, And you could try lawnmowering or just moving your probe systematically through the right lower quadrant. And if those don't work, then you could try the left posterior oblique position. Have the patient turn all the way to their left side, and then you place the probe just lateral, just right on their flank to try to look behind the cecum. And you don't forget to try the right upper quadrant as well, especially in the smaller or pediatric patients. Now, where are we looking for exactly when we're concerned someone may have appendicitis specifically and inflammation of the appendix? Well, these are the ultrasound findings. And the most important one, the most common one you'll see is a dilated appendix. And what does dilated mean? Dilated basically means the diameter of the appendix is greater than or equal to 6 millimeters. So in this image right here, you'll see the appendix in a transverse cross section right here. You're just gonna measure from the outer wall to the outer wall, anterior to posterior, straight across. And right here, you'll see this one is dilated to 9 millimeters, which is greater than our 6 millimeter cutoff. So this would be considered dilated appendix. And there's another image of that same appendix right here. And what I want, and this is in the other sagittal view, once you rotate the probe 90 degrees, you always need 2 views of each structure in order to truly call it that pathology. And this is important because in this view is how we find out if this is actually a blind ending tubular structure. Any other portion of the bowel would not be blind ending, but the appendix is the only structure in that area which would be a blind ended tubular structure. And also, very important, you have to make sure this is a non-compressible tubular structure because that's what indicates an inflamed, dilated appendix. So if you see in this image here, if I just pause it, go back to the beginning right here, you see this is like a cross-section of the appendix. And as you follow it, you keep following it, you're still seeing the appendix there, and you just keep following, and eventually it just disappears completely. And that's how you know it's a blind ending structure. And even better is and right here, you see the very end of the appendix, that round tubular blind ended portion. Here's a clear example of a very nice sagittal view of an appendix. And you see this tubular blind ended structure right here. And if you should be applying graded compression, this would be a non-compressible structure. Those are the 2 main findings, the diameter greater than 6 millimeters and a non-compressible blind-ended tubular structure. Here's some pretty important secondary findings of appendicitis. The first one is free fluid, as demonstrated in this image. You see right here, this dark anechoic space right there in between. This is the appendix right there, and these are just some loops of bowel. This anechoic part is the free fluid. And free fluid is it's just an indication that this appendix would likely have to be surgically managed. And there's also a higher chance of complications with this appendicitis, such as a perforated appendix, further indicating the need for surgery rather than just treating with antibiotics. And also sometimes you'll see this thing called target sign. Now, if I just pause this right here, can't pause this video, but you can see right there becomes a target, and you'll see basically the anechoic internal lumen of the appendix, and you'll see the hyperechoic ring and then another hypoechoic ring around that. Those are basically the multiple mucosal layers of the appendix. And when it's inflamed, you can see those layers more clearly giving off that target sign. Occasionally, you can see an appendicolith also, which is this bright hyperechoic structure right there within the appendix. And that's basically calcifications, and most commonly it's fecal matter or stool that kind of forms this ball that gets stuck on the proximal end of the appendix. And because of that, pressure and fluid builds up just distal to that obstruction, which causes this inflammation and eventually appendicitis. If you can see the appendicolith, that's also another indication that this patient will likely require surgery for management rather than just antibiotics for medical management. And occasionally you can see what's called a ring of fire sign. If you take color Doppler and place that over the appendix, and that basically indicates inflammation around the periphery of the appendix. This is a very non-specific sign. You could see this in any pathology that shows inflammation. Most common example is ovarian torsion, where if you put color over the torus portion, you'll see a ring of fire sign as well. All right, that's it for appendicitis. Any questions so far? There's time at the end also for Q&A. All right, great. We'll move on to small bowel obstruction now. Okay, so for small bowel obstruction, the most important part about anatomy is being able to differentiate the small bowel from the large bowel. Small bowel will have these structures here that stick out into the lumen called the plicae circularis. And anatomically, it looks like this. These are internal folds within the lumen of the small bowel. And they're very close together. And there's a lot more of these folds than there are of the folds that are in the colon or the large intestine, which are called haustra. These folds, these plicae circularis, increase the surface area within the small bowel so you can increase the rate of absorption. And they're basically going to be small outpouchings that are very close together. Whereas haustra within the large bowel are these outpouchings here, and they are not as close together as the plicae circularis. There are not as many of them, and they basically look like large pockets within the large bowel, like what you see right here, these large outpouchings, and those are what haustra are. That's how you tell the difference between small bowel versus large bowel. The technique for looking for a small bowel obstruction is you have the patient lie supine on their back. And again, you take either the linear curve or the curvilinear probe, depending on how large the patient is. Ideally, use the linear probe if it's a thin enough patient. And you can start either in the right lower quadrant or left lower quadrant. The key here is not to start too anterior, because if you're too anterior, like you see in this video clip, all this shadowing here, that's dirty bowel shadowing, like we mentioned earlier. Especially when you have dilated loops of bowel, you'll have even more pronounced air, like dirty air shadowing. And this is just a video clip of as one of my patients a few months ago, concerned for small bowel obstruction. It started anteriorly, and all you see was air. And then as you move lateral, that's when you see this clear image of actual loops of bowel. So start in the left or right lower quadrants. And again, you just lawnmower the probe, which means you systematically just go supine, and you go superior and inferior as you're moving the probe laterally. And these are the ultrasound findings that you'll see for small bowel obstruction. You could see the most important finding is, again, a dilated loop of bowel. And the number we want you to remember is about 2.5 centimeters dilated would be concerning for a small bowel obstruction. And basically find the most dilated loop of bowel that you could see, you freeze the image, and then you measure across, like right here, and you measure across right, as you see in this image right there. In this image here, you see we measure 2.9 centimeters across, which would be considered dilated. And this is where it's important to be able to differentiate a small bowel from a large bowel, because a large bowel obstruction is a higher threshold, which is about 5 or 6 centimeters actually would be considered dilated for a large bowel obstruction. So this is where it's important to be able to differentiate anatomically which one's small bowel and which one's large bowel. Just look for the plicae circularis or small bowel. And speaking of the plicae circularis, you see that right here, these little folds that stick out into the lumen, and they're very close together. And there's a lot of these folds in just one image. That's how you know it's a small bowel. And especially when the wall becomes inflamed and thick and edematous, you'll get this thick wall. And if you measure this wall, if you get it greater than 3 millimeters, that's concerning for wall thickness in a small bowel. And that's how you generate this sign called the keyboard sign. And keyboard sign is basically the plicae circularis inflamed and edematous, these outpouchings going into this anechoic lumen. And it just looks like the keyboard on a piano. So if you hear keyboard sign, that's a common finding that you see with small bowel obstruction on ultrasound. And again, you could also see free fluid, just like with a complicated appendicitis. You could see free fluid in the case of small bowel obstruction. And again, free fluid would indicate more likely that this patient would need surgical management rather than medical. And sometimes it could be difficult to tell what is free fluid and what's not. Like how do you, being able to tell fluid that's actually within the bowel, or if you're very low in the pelvis, like in this image, fluid that's within the bladder or urine, how to tell that from actual free fluid. You gotta look for a pocket of an anechoic pocket, a black pocket that's actually angular and almost looks like triangular, like you see right there. That's free fluid. Whereas if I pause it right there, this is the bladder. It conforms to the round shape of the bladder. Whereas here, this triangular, angular shape, that's actual free fluid. So it's important to be able to differentiate those two. There's actually an ultrasound name as well for free fluid in the setting of a small bowel obstruction, and it's called Tenga sign. Now, Tenga sign, fun fact, Tenga is actually not the name of a famous physician. It's the name of a bikini, actually. And the triangular shape of this free fluid is supposed to look like the triangular shape of the bikini. And that's why it's called Tenga sign. And that's one way that can help you to remember that you're looking for this triangular or sharp angular anechoic space, which would be the free fluid. And as you see in this image here, it's very important to be able to tell this free fluid from this fluid here, which is actually within the lumen of the small bowel. You're actually looking for these sharp angular portions. Same right here, these sharp angular portions, and right here as well. That is free fluid versus right here is actually fluid within the lumen. And you can also see an akinetic bowel, meaning the contents within the bowel are kind of just hovering in the same spot, not really going in any one direction. And when you see that, or if you see alternating peristalsis, where it's basically back and forth movements of the bowel, not really moving in one organized direction, this tells you that there's a transition point somewhere distal to this point where you're seeing the peristalsis. And that we can't find specifically where the transition point is on ultrasound, or at least there's no systematic way to find it, because on ultrasound it's difficult to actually follow a loop of bowel continuously just based off of anatomy and the limitations of ultrasound. But if you see this peristalsis, it does tell you that there's a transition point somewhere distal to this point. And it's an important finding to show your surgeons too, because they do frequently ask for the transition point. It helps them with their surgical management. If you show them this, along with other secondary signs, such as free fluid and akinetic bowel movements, that could raise their level of suspicion for a type of SBO that would require surgical rather than medical management. So that's the importance of these secondary findings to help you coordinate care with your surgeons so that you can kind of, it acts as a prognostic factor for how likely you think this patient would require surgical management rather than medical. That's it for the talk. So in summary, for appendicitis, number one tip is just start where it hurts the most. Try the left posterior oblique position of the right upper quadrant. Also, if you're concerned for a retrocecal appendicitis, you're looking for primarily a dilated appendix and a non-compressible blind-ending pouch. A dilated appendix is greater than 6 millimeters. And for a small bowel obstruction, to differentiate small bowel from large bowel, you're going to be looking for the folds, the outpouchings into the lumen called plicae circularis for the small bowel. You're looking for the more separated and wider outpouchings called haustra for a large bowel. You're going to start in the right and left lower quadrants. Again, graded compression. You're going to lawnmower, and you'll be looking for a dilated loop of bowel with a diameter greater than 2.5 centimeters, along with alternating or back and forth peristalsis. All right, thank you, everyone. Please let me know if you have any questions.
Thank you so much, David. That was a very wonderful presentation and really enlightening. I would just like to pause for a bit and find out if anyone from the group has questions. If you do have questions, please unmute and ask.
And I can see the chat now, so if you guys just want to type into the chat, that's fine too.
Any questions from the group? Okay, I guess it was a very elaborate presentation and everyone understood. So we have no questions. Just before we close, I would like to make an announcement to the group. As you're all aware, the AFEM conference, the AFCAM, is happening this November, and there's a call for people to apply for sponsorship to attend the conference. So just to inform everyone that the deadline is this Sunday, and I'm going to post a link for you to apply. Please make sure that when you are applying, you mention that you're part of Delta. That's if you're a Delta member. And we are looking to having as many representatives as possible. I'm just going to repost the link in the chat for you to find, and just give 1 or 2 more minutes for anyone who has a question to then unmute and ask.
Yeah, a couple of questions in the chat. So first, how to differentiate appendicitis from psoas abscess? So psoas abscess, we actually saw the psoas muscle, and you actually see the abscess within the muscle itself. And whereas for appendicitis, again, you just have to look for specifically a blind ending tubular pouch, and that's not what an abscess would look like. And also, how would ileus or partial obstruction be differentiated from complete intestinal obstruction on ultrasound? Sometimes it's hard to tell. And a lot of times you won't be able to completely differentiate. And that's where you have to get your surgical colleagues involved as well. And you can't just go off of the ultrasound findings complete on its own. You have to go by the patient, like how they're presenting and the story. Like, do they have a history of complete obstruction? Are they actively vomiting? That may point more towards complete obstruction rather than just ileus. And complete obstruction would I would think, would more likely give you those secondary signs, such as the akinetic peristalsis and the to and fro peristalsis. Whereas ileus or partial obstruction, maybe you'll just see a dilated loop of bowel rather than those secondary findings as well. And the sensitivity of target sign in appendicitis versus intussusception, I'm not sure about the exact sensitivity, but target sign, I would think it's neither sensitive or specific, especially since you see it in a lot of any other pathology that involves a round tubular structure and inflammation, such as ovarian torsion. And let's see, CT, they talk about transition point, which invariably confirms obstruction. How to identify transition point on ultrasound? It's a great question. There is no systematic way to look for a transition point on ultrasound. You can only look for the secondary signs, because if you imagine loops of bowel, and especially the small bowel, the way it's organized anatomically in the abdomen, it's impossible to follow it on ultrasound specifically, and because you don't know which part is more proximal or distal, and you're not sure exactly where you are in the small bowel specifically, just based off ultrasound on its own. But because it's impossible to follow it, it would be impossible to look for the exact part of the transition point. However, if you do see the to and fro peristalsis or akinetic peristalsis, that does suggest strongly that there is a transition point distal to that point where you see the to and fro peristalsis. And sometimes that's enough just to convince your surgical colleagues to take them straight to the operating room without a CT in order to do an exploratory laparotomy, especially if the patient is unstable, especially if they have a history of small bowel obstructions, or any history that suggests this could be a small bowel obstruction, like recent surgery. So sometimes just seeing the secondary signs is enough to have them be taken to the operating room. And that's really the goal, is to get the patient to their final management, definitive management, as quickly as possible. That's your goal in the emergency department, not necessarily to find a transition point. It's just to get them to manage point A to point B to management as quickly as possible. Any other questions? All right. Well, thank you, everybody. This is great.
Thank you, David. Thank you so much. Would you be so kind to share the slide as well?
Yeah, absolutely. I will email it. We'll email it out. Thank you.
Perfect. Thank you so much. We look forward to having everyone join us for the next session as well. But thank you so much for your presentation.
Thank you, everyone.
All right. Bye.
Thank you very much.